Transplantation surgery represents a pinnacle of medical achievement, offering hope and renewed life to patients facing end-stage organ failure. This field encompasses a range of surgical procedures aimed at replacing diseased or non-functioning organs with healthy ones from donors. From kidney and liver transplants to heart and lung replacements, transplantation surgery has transformed the landscape of modern medicine, providing a lifeline for countless individuals worldwide. In this presentation, we will delve into the intricate world of transplantation surgery, exploring the principles, challenges, and breakthroughs that define this remarkable field. In the realm of transplantation surgery, understanding key terminology is essential. Here are some fundamental terms. 1. Transplant. This refers to the process of transferring an organ or tissue from a donor to a recipient, often referred to as the host. 2. Isograft. This type of transplant occurs between genetically identical individuals such as identical twins. Isografts typically have a minimal risk of rejection due to genetic similarity. 3. Autograft. In an autograft, tissue is transplanted from one part of the body to another within the same individual. Common examples include skin grafts and vein grafts. 4. Xenograft. A xenograft involves the transplantation of tissue or organs from one species to another, for instance, using a porcine heart valve in a human recipient. Xenografts pose significant immunological challenges due to species differences. The immune response to transplants involves intricate processes that can influence the success or failure of the graft. Here are key components. 1. Antigen-presenting cells, APCs. These cells play a pivotal role in the immune response by processing and presenting antigens to T cells via the major histocompatibility complex, MHC. This interaction triggers an immune response against the graft. 2. Acute rejection. This type of rejection typically occurs within the first 6 months post-transplantation and involves both cellular and/or humoral immunity. In severe cases, hyperacute rejection can manifest within hours of transplantation. 3. Chronic rejection. Unlike acute rejection, chronic rejection develops after the initial 6-month period. It is characterized by T-cell-mediated fibrosis and arteriosclerosis in multiple organs, leading to progressive graft dysfunction and failure over time. Managing transplant rejection is crucial for the long-term success of the graft. Here are the treatment strategies for different types of rejection. 1. Acute rejection. This is typically treated with high-dose corticosteroids and immunosuppressants to suppress the immune response and prevent further damage to the graft. 2. Hyperacute rejection. Unfortunately, this type of rejection is often refractory to therapy and may necessitate the removal of the graft to prevent systemic complications. 3. Chronic rejection. As fibrosis progresses and chronic rejection sets in, the only effective treatment may involve replacing the graft with a new one to restore function and prevent further deterioration. Graft versus host disease presents the opposite scenario to rejection, where donor cells attack the recipient's organs instead of vice versa. Here's an overview. 1. Common in bone marrow transplant and hematopoietic stem cell transplantation. Graft versus host disease is frequently observed in bone marrow and hematopoietic stem cell transplants, particularly when there is a human leukocyte antigen, HLA, mismatch between the donor and recipient. 2. Systemic effects. Graft versus host disease manifests with a range of systemic symptoms, including hepatitis, liver inflammation, pneumonitis, lung inflammation, gastrointestinal and genitourinary dysfunction, as well as skin rashes and lesions. 3. Treatment. Management typically involves systemic steroids to suppress the immune response, along with immunosuppressants like cyclosporin. Additionally, targeted therapies may be employed to address specific aspects of graft versus host disease pathology and mitigate its effects on the body. Isograft transplants offer unique advantages due to their inherent characteristics. 1. Zero rejection risks. Since isografts occur between identical twins who share the same genetic makeup, there is virtually no risk of rejection. This makes isografts an ideal option for transplantation, as the immune system recognizes the transplanted tissue as self. 2. Convenient transplants. Isografts are considered the simplest type of transplant to perform successfully due to the absence of rejection concerns. The identical genetic background minimizes the need for immunosuppressive medications and post-transplant monitoring. 3. Valuable for study. Isografts serve as invaluable models for studying transplant immunology. By eliminating rejection variables, researchers can focus on other aspects of transplantation, such as tissue regeneration, immune response modulation, and long-term graft survival. This makes isografts essential tools in advancing our understanding of transplantation processes and improving transplant outcomes. Autograft transplants offer specific advantages owing to their unique nature. 1. Patient's own tissues. Autografts involve utilizing tissues harvested from the same individual receiving the transplant. For example, in coronary artery bypass surgery, surgeons commonly use veins harvested from the patient's own body as grafts to bypass blocked arteries. 2. No rejection risks. As autografts utilize the patient's own tissues, there is virtually no risk of rejection. The immune system recognizes the transplanted tissue as self, eliminating the need for immunosuppressive medications and minimizing post-transplant complications. Autografts play a crucial role in various surgical procedures, particularly in coronary artery bypass surgery, where they contribute to restoring blood flow to the heart muscle without triggering immune-mediated rejection responses. Xenograft transplants involve several key aspects. 1. Animal donors. Xenografts utilize tissues or organs from animal donors, such as porcine heart valves, to replace damaged or dysfunctional human tissues. 2. High rejection rates. Xenografts pose a significant risk of hyperacute rejection due to the presence of foreign antigens in the animal tissue. The recipient's immune system often mounts a rapid and aggressive response against these foreign antigens, leading to graft failure. 3. Ideal donor species. Pigs are considered the most suitable non-primate species for xenotransplantation due to physiological and anatomical similarities with humans. Despite this, significant immunological barriers still exist, necessitating ongoing research to overcome rejection and ensure the success of xenograft procedures. Acute rejection in transplant surgery involves several key characteristics. 1. Vascular inflammation. Acute rejection leads to inflammation of blood vessels, a process known as vasculitis. This inflammation can impair blood flow to the transplanted organ, leading to tissue damage and dysfunction. 2. Cellular and humoral immunity. Acute rejection involves both cellular and humoral immune responses. T cells play a central role in cellular rejection by directly targeting and attacking the transplanted tissue. Meanwhile, antibodies produced by B cells contribute to humoral rejection by recognizing and attacking foreign antigens on the transplanted organ. 3. Early onset. Acute rejection typically occurs within the first 6 months following transplantation, although it can occur earlier in cases of hyperacute rejection. Prompt diagnosis and treatment are essential to prevent graft failure and improve patient outcomes. Hyperacute rejection is a rapid and severe form of rejection that occurs shortly after transplantation. Here are some key points. 1. Swift onset. Hyperacute rejection typically occurs within hours or days of transplantation, making it one of the earliest forms of rejection to manifest. 2. Antibody-mediated. This type of rejection is primarily mediated by preformed recipient antibodies against donor antigens. These antibodies recognize the foreign tissue and trigger an immediate immune response, leading to tissue damage. 3. Vessel thrombosis. Hyperacute rejection often results in rapid thrombosis and occlusion of blood vessels within the transplanted organ. This ischemic injury further exacerbates tissue damage and compromises graft function. 4. Refractory to therapy. Unfortunately, hyperacute rejection is refractory to treatment with immunosuppressive medications. In most cases, graft removal becomes necessary to prevent further complications and preserve patient health. Chronic rejection is a gradual and insidious process characterized by persistent immune-mediated damage to the transplanted organ. Here are some key features. 1. Fibrosis and scarring. Chronic rejection results in widespread fibrosis and scarring within multiple organs. This fibrotic tissue gradually replaces the normal functioning tissue of the transplanted organ, impairing its function over time. 2. Arteriosclerosis. One hallmark of chronic rejection is the development of transplant arteriosclerosis, a progressive narrowing and hardening of the arteries supplying the transplanted organ. This arteriosclerotic process further compromises blood flow and organ function. 3. T-cell-mediated immunity. Unlike acute rejection, which may involve both cellular and humoral immunity, chronic rejection is primarily driven by T-cell-mediated immune responses. Persistent T-cell activation leads to chronic inflammation and tissue damage within the graft. 4. Progressive nature. Chronic rejection typically occurs months to years after transplantation and progresses slowly over time. Despite ongoing immunosuppressive therapy, it remains a significant challenge in long-term graft survival. When evaluating transplant recipients for signs of rejection, it's essential to recognize the distinct features associated with each type. 1. Acute rejection. Characterized by vasculitis, acute rejection involves inflammation of blood vessels within the transplanted organ. This acute inflammatory response can lead to tissue damage and dysfunction. 2. Hyperacute rejection. Rapid and severe, hyperacute rejection is marked by vessel thrombosis, resulting in the sudden occlusion of blood vessels supplying the transplanted organ. This rapid thrombotic process compromises blood flow and can lead to immediate graft failure. 3. Chronic rejection. Distinguished by fibrosis and arteriosclerosis, chronic rejection is a slow and progressive process characterized by the accumulation of fibrotic tissue and the narrowing of arteries supplying the transplanted organ. This chronic scarring and vascular damage gradually impair organ function over time. In contrast to rejection, graft versus host disease involves the donor's immune cells attacking the recipient's organs, creating a complex immune reaction. Commonly observed in bone marrow and stem cell transplants, graft versus host disease occurs due to human leukocyte antigen, HLA, mismatch between donor and recipient. GVHD manifests with systemic effects affecting various organs, including hepatitis, liver inflammation, pneumonitis, lung inflammation, gastrointestinal, GI, and genitourinary, GU, dysfunction, and skin rashes. These manifestations reflect the immune system's response to the recipient's tissues, leading to tissue damage and dysfunction. Management of graft versus host disease typically involves a multi-pronged approach aimed at suppressing the immune response and mitigating tissue damage. 1. Systemic steroids. High-dose corticosteroids serve as the cornerstone of graft versus host disease treatment, exerting potent anti-inflammatory effects to dampen the immune reaction. 2. Immunosuppressants. Medications such as cyclosporin, tacrolimus, and ibrutinib are commonly utilized to further suppress the immune system and prevent the escalation of graft versus host disease. 3. Targeted therapies. Emerging biologic agents like etanercept and alpha-1 antitrypsin offer targeted approaches to modulate specific pathways involved in graft versus host disease pathogenesis, providing additional options for refractory cases. The selection of treatment modalities depends on the severity and clinical presentation of graft versus host disease, with the goal of achieving immune tolerance and preserving organ function in transplant recipients. Transplant immunology research plays a pivotal role in advancing our understanding of graft acceptance, rejection, and immune modulation. Key aspects of this research include 1. Isografts. Isografts, which involve transplants between genetically identical individuals, offer an invaluable model for studying transplant immunology. By eliminating major histocompatibility complex (MHC) disparities, isografts provide insights into immune responses and tolerance mechanisms. 2. Advancing knowledge. Ongoing research endeavors seek to deepen our understanding of the complex interplay between donor and recipient immune systems, with the ultimate goal of improving transplant outcomes and reducing the incidence of rejection. 3. Innovative therapies. Research efforts are focused on the development of novel immunosuppressants and targeted treatments that can selectively modulate immune responses, minimize graft versus host reactions, and promote long-term graft survival. By harnessing the insights gained from transplant immunology research, clinicians and scientists are poised to revolutionize transplant medicine, ushering in an era of improved patient care and enhanced graft longevity.